presenting on sarcopenia, pelvic floor dysfunction, and surgical outcomes. We actually have a small room here, so I'll be making eye contact with all four of you here. Our purpose today is to share the status of our work made possible by the Seed Grant funding. So special thank you. And this is not my work at all alone at all. I'm also presenting the work of Dr. Layla Nashadian and Dr. Lauren Becker, both from GI, and Dr. Vipul Sheth from radiology. And special thank you to Spire, who listened throughout the entire time about our work and is partnering with us. So I'm going to show you two examples of aging. The 90-year-old who is still climbing the Alps, and he has a wonderful little interview that is on the New York Post. And the gentleman who's possibly 10 to 15 years younger who can barely get out of bed with his walker. Now I'm going to show you the quadriceps in the mid-thigh of a 40-year-old triathlete and then a 70-year-old triathlete. Both of them have a lot of muscle, and you can see the status of the femur. And now you look at this 74-year-old sedentary man, and it's filled with fat. There's very little muscle, and there are some distinct differences. So that makes us think about this idea about sarcopenia, which is a decline in muscle mass and function. And then from I like to bring it to the personal, like we like to think about how we'd like to age, but also as surgeons, when we look at two of those patients, we think about which of the patients we would prefer to operate on, the healthier one versus not. So we know that this idea of sarcopenia can be measured via different imaging parameters that I just showed you, and that increase in aging and increase in frailty is associated with sarcopenia and poor medical outcomes. I didn't need to tell you that. It's in the literature, but you already knew that from your own experience. Now, I work on the pelvic floor area, so sort of down south, and this involves a series of skeletal and smooth muscles that supports the internal organs of the pelvis. Pelvic floor dysfunction, which is involved in the organs that are down on the pelvic floor, can lead to prolapse, bowel, bladder, sexual dysfunction, and pain. And 1 in 5 women suffer from pelvic organ prolapse or incontinence. So looking at the prevalence with age, the likelihood of a woman, and this is over 7,000 women were both surveyed and examined, the likelihood of developing one or more, either pelvic organ prolapse, fecal incontinence, urinary incontinence, increases over time. So even in the 50s, it's at about over 30%. But by the age of 80, one or more of these is going to be reported in 52% of women. So that comes to the Pelvic Health Center, which I was I worked on here at Stanford. And this is really a think tank of different specialists. And these are your urologists, your gynecologists, pelvic floor PT. You may recognize a lot of them. And that's Dr. Nashadian from GI. And we really spend a lot of time looking at what's clinically known and what are the knowledge gaps. Since I've been here, I've worked on this outcomes tracking tool, like what's happening with my surgical outcomes. And that's Nick and Maddie, who are really actively working on us capturing that. We needed an imaging tool, and Dr. Sheth has been working on MR defecography, which is a way to evaluate both the anatomy and the function. And really important to look at multi-compartment anatomy and function. And then Dr. Becker, oops, I flipped too fast, but Dr. Becker, who's looking at immunoprofiling. So we sat together and said, can pelvic floor muscles exhibit sarcopenia in otherwise healthy patients, right? We've got these younger patients who are already exhibiting different prolapse. Is sarcopenia a marker for prolapse recurrence? And can we identify patients who might benefit from triathlon training of the pelvis? So some sorts of interventions that we could improve. So this comes to our grant aims, which are way too many grant aims for 1 year, but I'm an overachiever. So to determine whether sarcopenia is a risk factor for multi-compartment pelvic organ prolapse, we wanted to also study the association between sarcopenia and anorectal motion or pelvic floor strength, to assess the relationship between colonic tissue immunoprofile in patients with prolapse and sarcopenia, and to assess if sarcopenia is a risk factor for 30-day complications and prolapse recurrence. So we didn't expect to finish all of these, but at least to get these things in the work over this year with the grants. So many of you may not have ever seen a MR defecography, which is an imaging study that shows, it gives you a view. Now this, I don't think that the audio is working, so I'm going to audio and show you through it. And I'm showing this is a premenopausal woman All right. And this is going to show what you're looking at here is going to be the process of defecation with contrast in the rectum. And I'm going to show the different degrees of prolapse and things as they push. And so so here's the anatomy showing, and it's easier a little bit if I slow it, showing the pubic symphysis, the bladder, this is fibroids in the uterus, and the rectum. And that line is the pubococcygeal line, and that's our reference point. So above those, there are no prolapse. And with straining and defecation, those organs in normal situations will not drop below those lines, but in abnormal situations will drop significantly. So again, watching as someone pushes, I'm going to see, just at this video, fall through. Okay, so these are some fibroids in the uterus. All right, and now the cervix in this case is dropping below this pubococcygeal line, and I can see that the bladder is dropping below over here. And that arrow is pointing to the cervix below the line. And in here in the rectum, I can see the folds of the rectum, and those are those green arrows that are still in the anal canal, but they're slowly descending out. And then in this red line, which shows you the anal canal, the rectum can actually enfold on itself and descend all the way through and beyond the anal canal, and that's external rectal prolapse. And in this case, now the small bowel is dropping down, and the small bowel is in front of the rectum and behind the vagina. And you can see this is called an enteroceal and a cul-de-sac hernia. So this is pretty remarkable imaging showing you the different degrees of prolapse. So we're now looking at this relationship between sarcopenia and prolapse, and there's a couple questions we had to address before, moving forward, which was, how do we group patients with different degrees of prolapse? Because it's really a process as it goes through the canal. And then where should we take the radiologic measurements? Because there's really nobody's really looked at this before. And so there is a standard grading system for rectal prolapse. So you could either have no prolapse, or you could slowly see the folds kind of bulge in, which is called rectal anal intussusception. So it's just at the top, you kind of get a hint of it. As it goes down and goes through the anal canal, it's just above, it's inside of the canal, and then goes just to above the anal muscles. And then once it's out, it's external rectal prolapse. So there is a grading system that has been reported, but it's really used for MR. It is really used for fluoroscopic defecation. And in this case, someone's sitting on a commode. They're in a different position than an MRI. And we kind of classify to a low grade versus a high grade. And actually, this is another kind of imaging. This is someone sitting on a commode, and you can actually see with contrast in the rectum, the different folds of the rectum as they're pushing and defecating. So this isn't really a one-to-one with the MR defecography, and those are some of the challenges that we faced. So, so here, this is fluoroscopic defecography and MR defecography have not been validated for the Oxford degrees of prolapse. So I can't really say that what I'm using for that fluoroscope is exactly what I'm seeing with MR. And we had previously reviewed and looked at level of agreement between clinical prolapse and MR defecography. So we had already looked at that in our group, and that everybody that I sent to a clinical prolapse, we reviewed the imaging all together. So looking, and I'm simplifying it obviously because you don't need to know my pain, or our pain, but looking at many different ways to group, sort of said that those who are grade 0, 1, and 2 was very early and probably clinically insignificant. Grade 3 was somewhere in the middle, that we knew that the rectum was kind of bulging in, but not out. And I really kind of questioned the clinical significance. And grade 4 and 5 is really very bothersome and has a lot of symptoms. So next, where do we take the measurements? So for most sarcopenia, the psoas is the level of is the place where you take measurements. But we said, well, it's the puborectalis muscle is the largest muscle on the pelvic floor. We also looked at taking measurements there also. This was a manual process because it's not part of routine MR reporting. We had to do a separate evaluation and required changing the MR protocol. So the MRs that I looked at that I ordered in 2017, where I have the long-term outcomes on patients, I can't really use to evaluate because we've now updated the protocol to be looking at separate things for sarcopenia. So we looked at 88 patients. Most of them, their primary indication, they had the MR because they had some sort of symptom of constipation. This is how they were grouped based on what I described to you, kind of an early, less clinically significant grade 3 is that kind of wild card group that we're not sure what's going to happen with them, and then clinically significant grade 4 and 5. And age, pelvic surgery, hysterectomy, smoking, and cardiovascular disorders were all clinically significant or were statistically significant in this group. Then we looked at what was going to be the best way to measure. So was it going to be the psoas fat fraction, the muscle index, the puberoctalis fat fraction, the puberoctalis muscle index? So psoas fat fraction was significantly higher in women in all three compartments. So whether it be the rectal prolapse, uterovaginal, or bladder, this was the area to look at. So now we've determined that this is the best place to look. And then looking at the multivariate analysis, psoas fat fraction was the only independent risk factor for higher grades of rectal and bladder prolapse, independent of age. This moving forward is going to be where we'll be focusing. Now, we're also looking at doing anorectal manometry, which is a pressure testing, not unlike esophageal or other places where you measure where a catheter goes in, they're asked to squeeze, push, relax. And here we see that there's definitely association between the psoas cross-sectional area and both resting and squeeze tone. And we're early on the analysis of this group, but there's definitely correlations. And now looking at our tissue banking, and this is a little bit of a kind of a separate area, but all kind of interrelated. We've collected tissue on 25 patients, and we continue to do tissue collecting. And we've definitely found that the macrophages increase with age and with bowel incontinence scores. And it's not just numbers, but the kind of quality of the macrophages. And Dr. Becker is in the process and is publishing off of that. And we're really we're going to start looking specifically at the prolapse groups. And then not lastly, but the ultimate goal is to correlate this with surgical outcomes. And most recently, what we've been doing is looking at how are we going to measure the frailty in our group, and also partner with Dr. Arya, but using the frailty index. And have shown definitely, of course, between different operations, looking at recurrence rates, that we do have a difference. And ultimately, we will be going back to our MRIs using the protocol that we determined to look at long-term outcomes and recurrence rates for the different patient populations. So in conclusion, we explored a novel association between radiologic findings of sarcopenia and anatomic findings of prolapse and rectal function, and we continue to analyze our data. There's quite labor intensive, and so Dr. Sheth is investigating AI tools to report sarcopenia measurements, because right now it's manual process. Dr. Becker is exploring macrophages, both the quantity, like what we're seeing in the tissue, and the quality in the bowel, and have had some interesting relationships between that and functional scores. And we're correlating surgical outcomes using validated tools for frailty, looking to see if we can identify both high-risk patients and create strategies to avoid progression of pelvic floor dysfunction. And so I would end with a special thank you to the Department of Surgery for funding us. And